Okay, welcome to Cardiovascular Disorders and Conditions Part 2. In this Part 2 session, we are going to cover cardiac conditions associated with heart failure, cardiomyopathy, pulmonary hypertension, some of your valvular disease problems, aortic dissections and syndromes, endocarditis, venous thromboembolism, and peripheral vascular disease, and with hypertensive emergencies. Heart failure affects approximately 6.7 million adults, even our younger populations in the United States every year have a condition associated with heart failure. Essentially, heart failure is a response to cardiac dysfunction, and a condition in which the heart cannot pump blood at the volume required to meet the body's needs. In any one of these conditions, it impairs the ability for the ventricles to eject blood to the systemic circulation. Patients who have had a STEMI may end up having a complication of heart failure, but can occur from other problems as well. And it can lead to things like myocarditis, endocarditis, cardiomyopathy, and those are things that can actually cause heart failure as well as uncontrolled hypertension. So essentially, acute heart failure definition, as I stated, is a heart's inability to meet the demands of the tissue that is essentially taken away abruptly. So they don't have enough oxygen to meet the metabolic needs of the body. I want you to associate acute heart failure with a decompensation state, meaning low cardiac output, the same as cardiogenic shock. So it's severe enough to reduce that cardiac output, placing the patient in cardiogenic shock. Heart failure is progressive, and its symptoms manifest how far the ventricular remodeling has occurred and that dysfunction of the heart itself as it advances and produces less cardiac output, essentially creating this left ventricular dysfunction. And as you can see, the various stages here, from early stage A, down to stage D in advanced heart failure, gives you an idea about the symptoms and the progression of the disease itself. So it's classified as either systolic versus diastolic. It's classified as well as a pump problem versus a filling problem. So if it's a pump problem as a primary problem of the heart failure, we call that systolic heart failure. So essentially, when the heart gets boggy and it stretches, it's not able to produce that cardiac output and ejection from the left ventricle to meet the body's needs. In a filling problem, that is a diastolic heart failure, we have thickened myocardial tissue that allows less amount of volume to fill the ventricles, that reduces the volume that's available on ejection to the rest of the body. So systolic heart failure, classified by systolic, diastolic, pump problem versus filling problem, a high output versus low output, and low output is associated with cardiogenic shock or stage 4 heart failure. And then there's compensated versus decompensated. And in this classification, compensated and decompensation can move back and forth. It depends on the treatment modalities or what type of devices, for example, have been placed to help support cardiac output. And so we'll look at that a little bit more. Okay, so we have left and right failure, heart failure. Left failure, signs and symptoms, essentially, is listed here, but essentially it's when the heart fails and essentially cannot provide that cardiac output. They have increased systemic vascular resistance. Patient becomes hemodynamically as a high afterload, and the heart cannot compensate for that, backing up blood flow to the pulmonary vasculature, causing pulmonary edema, and all those other symptoms that we see associated with left-sided heart failure. Due to the systemic vascular resistance and that squeeze that occurs as a compensatory mechanism, the patient may become more cyanotic looking, cool, pale, diaphoretic skin, and then backing up further into the right side, having right-sided failure. You can see the symptoms listed there as well. So commonly, left ventricular failure will produce right ventricular failure if there's no interventions that are taken to help reduce that. So you see the symptoms written on the screen there, and you do need to know the difference between the two. Now, a little bit about what's happening with heart failure. Like I said, essentially it's heart failure. When it's decompensated, we're synonymous for cardiogenic shock. There could be a cardiac anatomical reasons why this occurs, such as the valve that's insufficient, like mitral valve regurgitation, for example, ventricular septal defect. So there is an actual anatomical reason why blood will back up and produce low cardiac output. There could be a physiological reason, and this could be like a dysrhythmia. It could be an ischemic event like an acute MI, STEMI. It can also be from a non-cardiac problem as well, such as postpartum cardiomyopathy. It could cause from a virus or infection that we see with endocarditis, for example. So different reasons why heart failure may occur. What we do know is that when we start into the later stages of heart failure, there's just a downward spiral. Like I said, it's progressive. There's a decreased cardiac output. And because of that decreased cardiac output, our compensatory mechanisms start to kick in. There's a sympathetic response that releases epinephrine, norepinephrine to increase the heart rate to help overcome the decreased cardiac output. Often this is not sufficient as it decreases filling time of the ventricles. There is the inability for the heart to actually respond to this big demand by increasing contractility, so it starts to fail further. Those receptors are triggered by the low cardiac output in our body, and that results in vasoconstriction, which will increase afterload in hopes to increase systemic vascular resistance will actually go up to help produce more cardiac output, and that's where you start to see the pale, cool, diaphoretic skin. The heart is just too weak. It can't overcome this increase of SVR, so it becomes more ischemic. That volume will stay in the ventricles longer and stretch the myocardium. That myocardium stretch releases that protein BNP, and it is a mild vasodilator, but it's not enough to overcome the failing heart. This will activate the neurohormonal response, which we'll talk about, and this will also increase the pressure in the left ventricle because of the backup, reducing blood flow cardiac output outward, but also pushing fluid the opposite direction into the pulmonary vasculature, causing hypoxia and dyspnea and your classic pulmonary edema type symptoms. Okay, let's tie this into what we learned about hemodynamics and apply it to the heart failure patient. So they have low cardiac output, they're going to have low stroke volume, high PA pressure, high PaOP pressure from the pressure in the left ventricle, and high SVR due to the vasoconstriction. So that's going to be your classic heart failure and cardiogenic shock. So remember, cardiac output equals heart rate times stroke volume. And your stroke volume is broken down by preload, afterload, and contractility. So when we look at our stroke volume, we're going to look at our preload first. And with fluid overload, our preload is going to be high. When we look at afterload, we look at our systemic vascular resistance, and that vasoconstriction results in an increase of SVR, so that will be high. And then finally, we look at contractility, and our contractility is actually going to be low because the heart can't pump to meet the metabolic needs of the body. So that's going to be your classic hemodynamics, and I added this slide in for your visual. So we have different classifications of heart failure based on our ejection fraction. So in heart failure with reduced EF, an EF less than 40%, that is going to put them in systolic heart failure. That is the majority of your patients with the classic symptoms that we see associated with heart failure, and the cause being of an overstretch of the myocardium. When you have heart failure with preserved EF, so the last one listed there, this is going to be your diastolic heart failure. And due to the decreased filling time, the patients will have low cardiac output to the body, but they're getting enough ejection fraction. They just can't send it out to the body. So that's going to be your least number of heart failure patients. We're not going to look at the two in the middle, which is heart failure with mildly reduced ejection fraction, or heart failure with improved ejection fraction. We are just going to look at the first one and the second one. So the first one, reduced EF, systolic heart failure. The one with preserved EF is going to be your diastolic pressure or diastolic heart failure, and the EF will be greater than 40%. Okay, when the heart begins to fail and cardiac output is no longer sufficient to meet the metabolic needs of the tissue, there are these compensatory mechanisms that will kick in hopes to help improve perfusion to the systemic system. So we're breaking these down under what we refer to as the neurohormonal compensatory mechanisms in heart failure. So the first response that occurs at sympathetic nervous system activation senses that low cardiac output, and it's its first attempt to actually compensate. So there is release of norepi and epi to increase that heart rate and improve blood pressure and hopefully improve cardiac output. Like we learned, this doesn't happen too long, that the heart cannot maintain that cardiac output alone by just increasing heart rate. The next stage is going to be, or not stage, but the next event that occurs is the heart failure with the RAS, or the renin-angioaldosterone system activation. And due to the low cardiac output, there's decreased perfusion to the kidneys that will activate that whole response that you learned about, resulting in vasoconstriction, retention of water, retention of salt, stimulation of vasopressin released from the hypothalamus, which will hold on to additional water and salt in hopes to hold on to some of that fluid to improve cardiac output. There's also the endothelium responds by sending mediators to activate this neurohormonal system again when heart failure has not improved. And essentially this just cycle continues to go over and over and over again. So the patient becomes more tachycardic, has more fluid retention, has more vasoconstriction. So essentially we're asking the dying heart to beat faster, beat harder, with more volume and more pressure. And so that will add to an additional stress response on the myocardium. So development of pulmonary edema is seen in heart failure patients, especially left-sided heart. As pulmonary disease progresses from the heart failure, there is a decrease in the oxygen and CO2 exchange. And this picture kind of depicts that. You see in the first picture, this is a normal process that proteins help keep the blood into the capillary beds so that fluid does not leak, maintains that hydrostatic pressure so fluids don't leak into the pulmonary vasculature. And a little bit of fluid that may accumulate is removed by the lymphatic system. But this is compromised in patients that have heart failure. They're not able to remove the fluids. The fluid volume will increase due to a change in the hydrostatic pressure, and that's usually from pressure backup from the failing ventricle, left ventricle, and therefore there is an excess of fluid that leads to patients developing pulmonary edema, or what we refer to as breathlessness and heart failure. They become short of breath on exertion. They have symptoms as they progress. The symptoms can be at rest. They will have the sensation of shortness of breath with pulmonary vascular congestion, orthopnea or difficulty breathing when laying in a flat position. They will have what we call paroxysmal nocturnal dyspnea, which is really a severe form of orthopnea, which the patient awakens from sleep gasping for air. A lot of times these patients will sit upright and sleep better in an upright position. May develop what we refer to as cardiac asthma, which is shortness of breath or dyspnea with wheezing, a dry, non-productive cough. You may hear rales at the bases, and as it progresses, they may have more of that gurgling of sounds of acute pulmonary edema. So breathlessness in our failure patients. Sometimes when patients end up having pulmonary edema, it may be challenging to understand exactly what the cause is. Is it cardiogenic, or is this a non-cardiogenic pulmonary edema like ARDS? And so essentially we need to kind of understand a little bit about what the underlying cause is to help us identify what that looks like as well. So like I said before, there's blood that, as you know, surrounds the alveoli, and blood is kept in the capillaries due to hydrostatic pressure. As the heart enlarges, like the left ventricle, that increase of the pressure can cause changes. And within around the or the alveoli, you have hydrostatic pressure and osmotic pressure, and between the two, it keeps a balance. But with this growing backup and pressure back into backward flow, I should say, this will change that. And essentially, water will move into the interstitial space. Not so much the alveoli, but into the interstitial space. In ARDS, you have an excessive fluids, but fluids will actually shift into the alveoli, and that's going to be the difference, is that membrane becomes leaky for patients with ARDS, whereas in pulmonary edema due to cardiogenic reasons, like heart failure, fluid stays into the interstitial space. The symptoms are essentially the same, whether it's cardiogenic versus non-cardiogenic, and we're going to treat a lot of the symptoms the same as we would. The underlying cause is what's different. Now, you will see some changes, essentially. For example, the breath sounds on a patient that has pulmonary edema from a cardiac reason, because of gravity, fluid will shift downward. So you tend to hear abnormal breath sounds at the bases, where in ARDS, you may see it throughout all lung fields. Also with pulmonary edema from non-cardiac or ARDS, you may actually see patchy areas on the x-ray due to like an injury, for example, or patchy all over the x-ray as well. Whereas in the pulmonary edema from cardiac or heart failure, you'll tend to see the changes at the basis of the lungs itself. You also may see an increased heart size, so we call that hypertrophy. And one of the complications that occurs in heart failure from all that backup pressure is it changes what we call the morphology, or the shape of the myocardium. It starts to resemble something like a bowl. And this is what we refer to as ventricular remodeling. And that can lead to different arrhythmias and other complications. So ventricular remodeling is something that we want to make sure that we can help reduce the effects of, and I'll talk a little bit more about that in a moment. So in early stages of pulmonary edema, you may see your patient in what we refer to as respiratory alkalosis due to the hyperventilation that we see in attempts to eliminate that carbon dioxide to help improve oxygenation by hyperventilating and gas exchange. As that progresses, they become hypoxemia, you might start to see them move into the acidotic state. Essentially, oxygen just can't get into the alveoli. It's there, it just can't get into the alveoli, and that's due to all the fluids that are accumulating. All right, so our goals of treatment here is we're going to optimize oxygen delivery, and essentially that's what we want to do. So we want to help relieve the symptoms, enhance the cardiac performance, correct precipitating causes. So if they've had a MI, for example, how are we going to revascularize? That might be a patient that goes to the cath lab. They might need a CABG, for example. If they have a valvular problem, they need to go in and have a valve repair. If they're having dysrhythmias, we may put them on an antidysrhythmic or place an ICD as well. We also want to help manage the fluid overload. We want to improve cardiac output by decreasing systemic vascular resistance and increasing contractility. So how do we do that? With preload, we want to reduce preload. Remember, that will be high, and we're going to use diuretics to do that, to decrease the preload and eliminate excessive fluid from the body. And afterload, or one thing I do want to say about that is the cautionary piece of using diuretics are some of those electrolyte imbalances that can also lead to arrhythmias. So we want to make sure that we monitor their magnesium, their potassium, and also their sodium. You also want to look at calcium as well, as that is a important electrolyte needed in electroconduction of the myocardium as well. Afterload, we want to reduce SVR by decreasing, by vasodilating, I should say. So you might use a vasodilator like nipride, nitrates. This will help reduce both preload, afterload, and helps to improve cardiac output. Sublingual nitroglycerin can be used as well, or IV. Some of the side effects for that, we just want to be cautionary, is if they're in cardiogenic shock. We don't want to drop their pressure too much, and that can cause some vasodilation. They also can report a headache if they've taken nitro. We also want to help support the myocardium by enhancing cardiac output, and that may be use of positive inotropes, so medications like dopamine, dobutamine, or milrinone. They are both inotropic and vasodilatory effects as well. You also want to use beta blockers. Beta blockers have a negative inotrope response. They will help reverse left ventricular remodeling, as I just talked about the problems with ventricular remodeling. And those that do have significant ventricular remodeling have an increased risk of sudden cardiac death. Just remember cautionary with patients with asthma when you give a beta blocker. We don't like to use calcium channel blockers with heart failure patients because of the decreased contractility that can occur with calcium channel blockers. So they already have low cardiac output, so we don't want that to be reduced anymore. There are some newer medications on the market right now. They're called ARNIs, or angiotensin receptor neprisilone inhibitors. You won't need to know those. Those are an example of Entresto. You may have seen the commercial around those, but we're not going to use those in this lecture at all. And then you also want to use your ARBs and your ACE inhibitors. Your ACE inhibitors are going to help with the remodeling as well. And the ARBs as well will help reduce the RAS stimulation that occurs and holding on to all that fluid and water. So essentially, your medications are used to help reduce compensatory mechanisms. So your diuretics, your ARBs, your ACEs, your beta blocker, and your inotropes are going to be the main medical management for your patients. The only other medication that may be considered, patients with heart failure as they progress are more prone to having dysrhythmias, most commonly the atrial fibrillation, but they can also develop ventricular dysrhythmias. So we may put them on amiodarone, and sometimes these patients need to have an ICD placed permanently if it is not, if they're still having arrhythmias based on, even though they're on medications, antidysrhythmics. The other thing to consider is palliative care for end-stage heart failure. Is really focusing on symptom management and relieving some of those symptoms for quality of life. Optimizing medications is really the hallmark of heart failure. And then potentially having some of those pump support devices that are more available now with the advancement of technology to improve quality of life and actually longer life duration with heart failure. So this just kind of gives you just an overview of what we just talked about and how these medications might work in helping reduce some of the symptoms that you see. And a lot of the symptoms in heart failure are compensatory mechanisms, and so we're hoping to reduce that by the medication. So, for example, in the RAS system that's stimulated, you can see where ACE inhibitors have a role in reducing this response. Also with your ARBs in the remodeling and vasculature. These are other examples. Your mineral cortical blocking medications help block aldosterone. So example like aldactone and its role in reducing the stimulation of the RAS system as well within the kidneys itself. All of these in hopes to decrease systemic vascular resistance, help decrease the amount of fluid retention and water that are worsening symptoms for the patient. This is just a summary again of the medical management for your patients, the different medications that we're going to use. And I've already talked about these in the last couple slides. Just cautionary once again for patients that have shock present, and some of these agents like beta blockers would be contraindicated. And we even give beta blockers even at borderline heart rate and borderline blood pressure, because the role of reducing ventricular remodeling is so important that you may even see those patients on beta blockers even though their blood pressure is not very high. You may see on your slides the SGLT2 or I inhibitors, I should say. These newer agents out there, the injectables, for example, have a big role in diabetes, but they've also been found to be beneficial, not well understood yet, but beneficial in cardiac disease and help reducing heart failure. So that is another agent that you might see. The other ones to mention are your positive inotropes, like we talked about, dobutamine, dopamine, but also you do see patients that are still on medications like digoxin, which is the only oral positive inotrope available for patients at this moment. All right, so nursing management. We're going to monitor the EKG or ECG, monitoring for dysrhythmias, get a 12 lead if there's anything changed. Look to see if there's any type of electrolyte imbalances, potential medication toxicity. Also, auscultating those breath sounds. You want to make sure they're not developing worsening pulmonary edema or a new onset of pulmonary edema. Maximizing oxygen delivery if the patient is dyspneic, giving them lots of rest periods as well. Grouping activities. Administering medications like your dilators, your diuretics to help reduce preload, afterload, and diurese off that extra fluid. Morphine can be considered for the patient who's very anxious and hyperventilating. Just watch the blood pressure because it does has a vasodilated property to it as well. Patients could actually be on transition to something like BiPAP. This will help, the pressure itself will help displace some of that fluid and helps to diurese it off, and then have some of the lymphatic system remove fluids as well. If they fail BiPAP, then they may need to be intubated for vent support, mechanical vent support. So you want to restrict activities, keep them upright, maximize that lung expansion, keeping the head of bed elevated, the shoulders supported, legs in a dependent position to really encourage some of that venous pooling to keep too much fluid back up to the heart or core circulation. Monitor the vital signs before and after activities. Nutrition, as you can see, even in the most sickest patients, we start nutrition early. We need to promote nutritional intake for healing, whether it's through a gastric tube or oral. And then monitoring them via hemodynamic lines and looking at their hemodynamic parameters to assure that we are heading in the right direction. So these patients can be quite sick, as you've seen, so nursing has a huge role in the management of these patients. Okay, for education, patients and their families need to know a little bit about what is heart failure, how exacerbations can be prevented, low salt diets for sure to help reduce fluid retention, daily weights, doing a diary of weights every day once they get home. If they've got shortness of breath, when they need to reach out for EMS or come to the emergency department for possible admission. Also the medications that they're taking. A little bit about how they should do their activities of daily living, not overexertion, taking rest periods, those kinds of things. A lot of them may go home on anticoagulants, especially if they've developed conditions like atrial fibrillation. So they'll need additional information about risk for bleeding, risk for falls, risk for head injuries. When they're going to need labs drawn depends on the type of medications that they're going to be sent home on, and then what follow-up that looks like for the patient. Hey, just a little bit about some of these mechanical devices that can help support patients with advanced heart failure. So you have your balloon pump. You've seen those up on the units here. These will help patients augment cardiac output, allowing the heart to heal if need so. We continue with the medical management, nursing management we've already talked about. But essentially, you've got a balloon with a circulatory device that's helping to maintain perfusion, like I said, in cardiac output, usually placed in the femoral artery. The balloon will inflate during diastole, which will push the blood forward to the organs and backwards to the coronary arteries for perfusion. And then on a deflation, the balloon will deflate during systole, which is to help decrease afterload. Couple things to consider is that balloon catheter position. A complication could be decreased perfusion to the extremity. They can get a clot. They can have complete occlusion. So monitoring distal peripheral vascular assessment is super important. One of the contraindications for putting a balloon pump in would be aortic insufficiency. So if we've got a valve problem, that would be a contraindication. These patients also can get dysrhythmias. They can have other complications like an aortic dissection. The balloon could rupture, malposition. They can also develop thrombocytopenia because of the mechanical destruction of platelets by the pumping action of the balloon itself. Like I said, there are different devices to help support cardiac output for patients with heart failure. They're usually short-term in nature and do run the risk of quite a few complications. So, but they are out there and have been very successful, especially with bridge to like heart transplant or destination therapy like the VAD as well, the ventricular assist device. ECMO has been starting to be used more frequently in the critical care units. Its primary indication for patients with acute severe heart or lung failure, primarily for this population, it's going to be for our heart failure patients. So it is a temporary means of providing that support. In an ECMO patient with hemodynamic support, you have improved gas exchange, and you also have the mechanical piece to enhance hemodynamics. So it does both. So in your ECMO pulmonary support, this is for someone with just ARDS. If you have ECMO with hemodynamic support, it will actually do both, augment cardiac output and gas exchange for the lungs. This is an example of the Impella, which helps the left ventricle help support that cardiac output for someone that is in cardiogenic shock. Once again, temporary. And for a more long-term support, like bridge to transplantation, would be something like the VAD or vascular ventricular assist device. There are all kinds of different devices now available. The patients who are destination therapy means they are not candidates for heart transplant, and this is purely palliative to improve quality of life. But essentially, it is, although longer term, it's still a temporary fix. It's not going to fix the heart failure problem. The patient already has end-stage heart failure. Okay, so we're going to talk a little bit about cardiomyopathy. Cardiomyopathy essentially is treated and pretty much the same symptomology as someone with advanced heart failure. There's two types that we're looking at primarily. The one is the dilated and actually the hypertrophic. I think I have the arrow on the wrong one. So in dilated, this is your systolic heart failure. You have your overstretched myocardium. This caused usually from some type of ischemia event, alcohol, chronic alcohol use, pulmonary hypertension. So those means can, or a virus even, can cause systolic cardiomyopathy. And that is going to be your most common. Least common or less common is your hypertrophic. And so that's the one where the arrow should be on. That is diastolic cardiomyopathy. Like I said, the same as like heart failure, less common. Essentially, what happens is you have a change in the size of the heart chambers, but the myocardium itself does not change. It doesn't get bigger. So what that does is because the walls within the myocardium work harder, they hypertrophy, and essentially get larger like a muscle. So there's less room to actually fill with blood, and the walls are stiffer. So that's how you have reduced cardiac output with cardiomyopathy that is hypertrophic. In systolic, you have an enlarged heart. So you have hypertrophy of the heart itself. The entire heart is larger. And you've got a boggy heart, so therefore you can't produce that ejection well because the heart is too boggy. So synonymous to advanced heart failure, systolic heart failure and systolic cardiomyopathy fall under the reduced EF population. Filling is not compromised, but the pumping mechanism is reduced, so less than 40%. In diastolic heart failure and cardiomyopathy, diastolic hypertrophic cardiomyopathy, the filling is compromised by stiff ventricles. The pumping is not reduced. The EF is normal, but the cardiac output is reduced due to the low output from the stiff ventricles. Essentially, both restrictive and hypertrophic obstructive cardiomyopathy are pretty much kind of the same in sense of how cardiac output is decreased by these structural problems. It's just the underlying cause could be different. So one could be genetic, one can be from cardiac disease. You won't need to know anything other than systolic heart failure and what that looks like. That's your most common, your common heart failure patients. So we kind of described it, what it looks like. It's going to be very similar to your heart failure patients and their presentation. There is diagnostics that we would do. We would do a 12 lead on these patients. We would do an echocardiogram to kind of understand the EF and what the anatomy looks like, what the ventricular wall motion looks like. The symptoms, like I said, progression of cardiomyopathy can lead to that heart failure, left ventricular hypertrophy, symptoms very similar. Treatment is going to also be very similar, what we learned about in heart failure stage 4. and treating some of the underlying causes. So if it's from infectious cause, we would give antibiotics. If it's a ischemic cause due to like a STEMI revascularization, if it's due to arrhythmias, dysrhythmias, ablation therapy, or ICD might be the treatment. Okay, so the goals of management essentially is to resemble the same goals as symptomatic advanced heart failure: improve contractility, remove excessive fluid, control the heart failure symptoms, anticipate management of complications, and prevent sudden cardiac death. Nursing management will be the same, education will be the same. So whatever you learned in heart failure, you're applying it to the patient with cardiomyopathy as well. Systolic cardiomyopathy, or dilated is another name. Okay, pulmonary hypertension can lead to a progressive and ultimately fatal disease, and there are several contributing factors, such as elevation in the pulmonary pressures that occurs from heart failure and ultimately can lead to death. It can arise from isolated conditions, such as somebody has a infection or some type of congenital problem that can lead to a pulmonary disease. These patients generally can have high PAP greater than 20. They may have high pulmonary vascular resistance. This could actually result in a lot of vasoconstriction within the pulmonary vasculature, leading to remodeling, thrombosis that can occur as well. They can have changes and lesions that form in the pulmonary vasculature as well, really causing symptomology associated with the advancement of their pulmonary hypertension. So in class 1, patients may have some limit of activity. They may have some shortness of breath, may have some chest pain, or they may have had a near syncope. We're going to look to see if pulmonary hypertension is one of the diagnostic, or one of the differentials, I should say. If they get into class 2, they end up having more limitation in physical activities, more dyspnea at rest. Stage 3, they have marked limitations in physical activity, and really hard to, follow activities of daily living without getting symptomatic, like dyspnea, hypoxic, fatigue, chest pain. And then in stage 4, they really can't do much in terms of daily functions, all physical activities without having pretty severe symptoms. So it can be caused from a lot of different reasons. It can be idiopathic. It can be caused by genetics. It can also be caused by heart disease, such as heart failure, or lung disease, like ARDS. It can also occur from thromboembolic, like someone with PE or DVT. And sometimes we really just don't know. It's very unclear. So we're really looking to exclude other things that are causing some of the symptoms. So sometimes it's not very clear that this is a primary pulmonary problem that is affecting cardiac output, for example. So we're going to do some workup. We're going to look at diagnostic tests that look at exercise intolerance. This could be like the treadmill, for example. And there's other diagnostics out there that can help rule in or rule out pulmonary hypertension. We really want to get an idea of what the pressures are within the pulmonary vasculature. So we may put a line in and measure those pressures to see what's going on in terms of increased of pressure within the pulmonary vasculature. We already talked about some of the symptoms that patients may see and some of the underlying reasons why these patients may actually be end up diagnosis with pulmonary hypertension. But these patients unfortunately have pretty low quality of life, and we're really focused on treatment of some of their symptoms. Okay, medical management focuses on the use of appropriate pharmacological agents and help prevent complication, and our goals of therapy to include alleviation of some of the symptoms, improve quality of life and survival. Calcium channel blockers help to improve survival, some of the symptoms due to their vasodilation properties. You also have your endothelium receptor antagonist. Endothelium 1 is a potent vasoconstrictor, so an antagonist will help vasodilate the smooth muscles within the vasculature as well. Your phosphodiesterase inhibitors also promote the vasodilation and decrease the smooth muscle cells as well. Nitric oxide is a potent vasodilator, and you may have seen this in the ICU. Some of the patients were on NO for the heart failure. For the pulmonary hypertension patient. And then those are primarily the ones that we use. A lot of times the medications that we give, they may have to go home with some maintenance of therapy. And so a lot of education on the drug itself, reducing the effects of sudden withdrawal can cause rebound vasoconstrictions. We want to be very careful about that. We also might put them on anticoagulations if the patient's at risk of clot development, which we need to be careful about, bleeding as well, on those situations where we are using some of those anticoagulation therapies. So these patients can be quite sick. So once they've maximized their medical management in an outpatient setting at home, if they've decompensated, they are not having good oxygen exchange whatsoever, patients end up being admitted. They may end up going on ECMO temporarily, and really looking at ways to help reduce the pulmonary pressure by vasodilated medications that we give. So nursing management is going to monitor those symptoms, monitoring their hemodynamic status, making sure they've got their medication therapy on board. They may need to be treating pain, and sometimes a palliative consult will occur with these patients pretty early. Endocarditis. It's an inflammation of the endothelial surface of the heart with a thrombotic fibrin vegetation that occurs on and implants on the heart valves, can cause valve failure. It is an infectious organism, usually from a bacterial endocarditis, and it can be fatal if not treated, carries a high mortality rate in the first year, about 30%. High risk among patients with IV drug use. It usually has involvement of the right heart valves. If the patient has endocarditis secondary to IV drug use, it can occur from another infectious syndrome like urosepsis, pneumonia, abdominal, intra-abdominal sepsis. It has a higher risk with patients with congenital heart disease. And 75% of these patients with pre-existing structural problems with the heart valve have an increased risk of endocarditis or end up with endocarditis and needing a heart valve replacement. So essentially, these patients can be quite sick. They could develop bacteremia or sepsis. That bacteria proliferates and then develops these lesions that vegetate on the actual valves itself, resulting in valvular failure, which has a whole other set of problems that can cause heart failure, for example, for these patients. Okay, so for assessment and diagnosis, you won't need to know modified Duke criteria. It's just listed there just for your knowledge, looking at the etiology, because sometimes we don't even know what the etiology is. Definite diagnosis involves essentially positive blood cultures, imaging that shows the vegetation as well. Um, the chest x-ray, like I said, echocardiogram, and then also in looking at some of the complications. The patients may come in with heart failure. They could have an embolic complication such as a stroke, um, and also pulmonary embolus. So you're going to see these patients that may have an underlying cardiac condition, but they're also septic. And so one of the suspicious is if this is an endocarditis. So we will go ahead and do those diagnostics and see if we can rule them in. They may have all the symptoms, like I said, associated with like heart failure, but now we can understand the underlying cause. All right, your patient may present with symptoms such as fever. They may have an enlarged spleen, hematuria, petechiae, the cardiac murmurs from a valvular dysfunction of the heart valves. They may become very fatigued, almost flu-like symptoms, developing things like Ross spots, splinter hemorrhages, Osler nodes, and this is all due to a inflammatory response that leads to a vasculitis. These can actually form these complexes, deposits in the walls of small vessels, leading to some of these symptoms that we see, like the splinter hemorrhages, Osler nodes. And so those are diagnostic clinical symptoms associated with endocarditis. Okay, medical management, it's an infection. The only thing that's going to cure an infection is going to be antibiotics. They will be on long-term antibiotics for quite some time. Some will end up needing cardiac surgery or prosthetic valve if they've got persistent vegetation there. So valvular surgery may be something that's more imminent or may be something that they will have down the line. And these patients will always need to have some type of prophylaxis prior to any kind of procedures, like dental procedures, for example. So helping to prevent those complications is going to be early treatment with the right antibiotics, IV intravenous antibiotics. May go home with a PICC line to maintain long-term use of antibiotics, usually several months. And then monitoring the patients, looking at white blood count, monitoring their blood cultures, looking at their inflammatory markers, symptoms that they may have, consistent with sepsis, for example, any type of new vascular problems like that are consistent with like a microemboli. So they start to develop a rash, like petechial rash, or if these symptoms start to manifest itself again, like the Osler spots, things like that, or someone with sudden shortness of breath, tachycardia, loss of consciousness, pulmonary embolus might be the cause, and those are going to be some of the complications that we do see. Okay, so we're looking at valvular heart disease, and these are listed here on the screen of the various different types. And if you really look at the cardiac cycle, or you can kind of get an idea of what the symptoms may be when we've got someone with valvular disease. And if I know where those valves are, then I can help predict what some of the symptoms would be. So, for example, mitral valve stenosis. So you've got progressive narrowing of the mitral valve. This can be caused from something like rheumatic endocarditis. these patients, so because of where the mitral valve is, this can cause backup to cause high pressure in that left atrium that can lead to enlargement of the atrium. Atrial fibrillation can occur. Patient may have shortness of breath, fatigue, and weakness, and some of those symptoms that we see with heart failure. Mitral valve regurgitation, so you've got retrograde flow on any other regurgitation valve problems. So you have incompetent valves essentially. So depending on where that's at, the patient for a mitral valve, for example, is going to have fatigue, exertional dyspnea, some of the kind of the same symptoms. Aortic valve stenosis. Patient has aortic valve stenosis. Think of where the aortic valve is. It's narrowed because it's stenotic. This can be caused from aging, vasculitis. You're going to end up backing up into the left ventricle, so left ventricular hypertrophy, progressive left-sided heart failure, for example. The patient may have angina, dyspnea, syncope, all symptoms all associated with heart failure. And they can also have a decreased cardiac output as well. Aortic valve regurgitation, so incompetent valve again. This can lead to symptoms of the same left-sided dilation, hypertrophy, and the symptoms of backup into the pulmonary vasculature, so shortness of breath, palpitations, tricuspid valve, stenosis, stenotic valve. This is generally not an isolated lesion. We often see this occurs in conjunction with some other aortic disease or mitral valve disease. This can also be caused by rheumatic fever or IV drug use. Tricuspid valve regurgitation can result from advanced heart failure from all of that backup, and can lead to ventricular hypertrophy, dilation. It can lead to pulmonary hypertension and decreased cardiac output, and some of the signs of left-sided heart failure. So kind of look to see where is the lesion, or where is the structural problem, I should say, and this can help predict what some of the symptoms. Your pulmonic valve disease is really more common in your pediatric population due to congenital abnormalities, anomalies, I should say. So I thought this would be a nice picture to add in, kind of give you an idea of where those heart valves are, so you can get an idea of what some of the symptoms would be if that valve was affected. For NCLEX, you need to know a little bit about heart valves in terms of where you would listen to, where you would hear the heart sounds for the different valves, and what would that sound like? Would you have an extra S3? Would you have a gallop? Those kinds of things. So in your cardiac assessment handout that I sent you, you do have some mnemonics in there for you to review to kind of help you remember your valves and the location. So management of these disorders include medications to help control symptoms of heart failure, may have surgical repair or replacement of the affected valve itself. And that's generally what we see. So different types of valves out there that are available. It's really going to depend on how advanced the problem is. So things like low cardiac output is a common finding in patients with valvular heart disease. So those patients, we may need to get in and have hemodynamic support until we can get them the valve fixed. So supporting, giving them positive inotropes, help with cardiac output, just like we would for a heart failure patient. oftentimes we'll have those invasive lines again to monitor hemodynamics, also rest, as they can be quite fatigued, activity intolerance, fluids, balance, monitoring for abnormal heart sounds, monitoring for signs of pulmonary edema, fluid overload that we see in heart failure as well. And then really educating the family on what how to manage some of the symptoms at home, medications, fluid restrictions, need for those prophylactic antibiotics before any invasive procedures, and then when to seek medical attention if there are continued symptoms unresolved with treatment at home. So the team can formulate a plan. Here we're talking about acute aortic syndromes. You've got your aneurysms, your aortic dissections, and rupture would fall with that as well. About 20% of cases are thoracic aortic aneurysm. And this can be caused from chronic hypertension, also with history of smoking increases that risk as well. Other non-atherosclerotic disease or things like blunt trauma can cause this to occur. Marfan syndrome and pregnancy can also be a risk factor for developing aneurysms. So an aneurysm is a dilation of the arterial wall that results in alteration in the vessel shape and blood flow. And you can see the different types down there, the fusiform versus the saculated. That's really tells you about what it looks like. This can actually be detected sometimes just on exam by palpating the abdomen and feeling that pulsatile mass in the midline of the abdomen. Aneurysm less than 4 centimeters can be managed as an outpatient, monitoring the blood pressure, giving them medications, ultrasounds, looking and monitoring the size of the aneurysm. When it's about 4 to 4.5, we talk about shared decision making. Maybe we need to go in and possibly do some surgical repair or placement of a stent to help eliminate the risk of rupture itself. And then it's really going to also depends on what it looks like, what that approach would be, and how we might be able to repair it. So we also want to address the atherosclerosis that can lead to this as well, and the patients being on the statin. So you've got essentially a description there that shows that weakened wall there, and that would be an aneurysm, so an outpouching. In a dissection, you are forming a false lumen between the layers of the vessel itself, so blood will accumulate there. And as you see, if blood continues to accumulate there, the patient can rupture, and that can lead to an imminent death if we don't get them to surgery right away. So you can see this aortic dissection occurs when the column of the blood separates in the vascular layers. So you can see that false lumen, which communicates with the true lumen through a tear in the intima. So that's what's happening in the vessel itself. And there's different classifications. You don't need to name it per se, but kind of understand, what would be the presentation. So you've got that type 1, that first one that you see there, or type A. The clinical presentation is a sudden onset of intense, severe, tearing type pain, localized usually in the chest or abdomen or back. As the aortic starts to tear or dissection occurs, the pain can radiate to the back or down to distally to the lower extremities. Many patients with thoracic aneurysms do not always present with pain, but definitely tearing pain is a big one. So patients may be severely hypertensive. They may have decreased peripheral pulses. They have signs of limb ischemia. They may have a new murmur or aortic regurgitation that wasn't there before. In the descending one that you see in type 2, typically creates pain that radiates down the back, abdomen, or legs. And as you can see in the different pictures, that depending on where that dissection occurs, in the type 1, you can see it's in the ascending or up part of the aorta, and in a type 3, you are in the descending part of the aorta. So you can see that you won't get perfusion to those vessels in an ascending aortic dissection, and that would be your carotids, your coronary perfusions decreased. So those patients have a high risk of mortality. So for assessment and diagnosis, it's going to depend on severity of the patient's status. A TTE may be performed, gold standard CT when patient's having symptoms suspected of, or ultrasound or MRI, and then potentially having an angiogram to confirm diagnosis. Patient is a high risk, is hemodynamically unstable, then these patients may immediately go to surgery. Sometimes we may see on x-ray, that chest x-ray, a widened mediastinum, which is diagnostic for an aortic aneurysm dissection. And those patients may need to go straight to the OR. They are at risk for sudden death, and also cardiac tamponade can occur. And cardiac tamponade, or Beck's triad, is essentially that can occur with someone that has fluid around the pericardial sac that's not allowing the myocardium to pump, and therefore reduces cardiac output or puts them in cardiogenic shock. And so those are generally going to be your narrowing blood pressure, muffled heart sounds, and JVD, and really poor cardiac output. So our treatment, medical management, we got to get that blood pressure down. So we need to bring that blood pressure down immediately. We need to type and cross blood, get prepared for surgery if we suspect a dissection, have blood on hold. Generally, we like to use Esmolol, which is a beta blocker, for patients with a suspected dissection. This will help reduce not only the hypertension, but also the shearing forces from the tachycardia that occurs with that sympathetic response. So we don't want tachyarrhythmias. We definitely don't want high blood pressure. So Esmolol historically has been the drug of choice, but we can also use Clevoprex, calcium channel blockers as well. So this is Clevoprex that you see there, or nicardipine would be another drug. All right, so we're managing the high blood pressure. We want to check pulses, compare them, preferably bilateral, check the pedal, the femoral, auscultate for any type of murmur. We're having them on an EKG. We need a 12 lead. They're at risk for having dysrhythmias. These patients often need invasive lines. Like I said, the medications, the beta blockers to reduce cardiac output, lower blood pressure, and also has a little bit of that vasodilation properties to decrease the blood pressure as well. But they are at risk for actually hemodynamic collapse. So we got to really monitor them really carefully. They're going to be in a lot of pain. So we want to give them medications, do a good neuro exam, because they could actually have a stroke as well from lack of perfusion to the actual brain from the rupture. Look for signs of paresthesias, paralysis in the lower extremities due to the loss of blood flow to the lower extremities as well as the kidneys. So these patients are pretty critical. Okay, looking at peripheral vascular insufficiency, we can categorize them in an arterial versus venous. What would arterial look like? These patients are going to have cool extremities. They may have pulselessness. Oftentimes, they're not edematous, but they may have pallor or dusky type appearance. They get pain more with walking or exercise, often like what we refer to as leg angina, due to it being arterial in nature. Venous, these patients tend to have warm extremities. They also often have a pulse. Pulses are present. They're going to be edematous. They may have that hyperpigmentation. Pain is worse with standing. Relief when they sit. And so those patients will need more of a venous Doppler. An arteriogram will need to be done for a patient we suspect arterial insufficiency, and look to see how much constriction is there. Okay, so essentially, peripheral vascular disease, or PVD, it's a group of conditions involving problems with the lower vessels. And peripheral artery disease is a type of peripheral vascular disease. So essentially, this is where the vessels get narrowed. Most common, it is the cause from atherosclerosis is the most common cause of arterial disease. Most patients have at least one risk factor of cardiovascular disease, such as which cause from like diabetes, smoking, hypertension, hyperlipidemia. Males seem to have this more often. It affects the vessels in the lower extremities, and essentially these patients have symptoms associated with pain at rest. They could have acute occlusion. They have some of those atropic tissue changes that you see there. They may have intermittent claudication, which essentially there's obstructed blood flow in the distal extremity. That blood flow, restricted blood flow, produces ischemia or angina of the legs to the muscles, known as intermittent claudication. They may have that cramping, aching pain while walking. It's often one of the first symptoms. Pain is usually relieved with rest. And then these patients they'll perform, you don't need to know this, but what's called the ankle brachial index, and this gives us the idea of how severe the peripheral artery disease is, essentially. As the disease progresses, pain can develop at rest, and if that occurs, there is risk of viability of that limb itself and requires immediate catheterization and surgical intervention to relieve that blockage and or restore circulation to the extremity. It can also occur from an occlusion, like a thrombosis that occurs. Your patients that have had punctures to the groin for any type of endovascular procedures, angiograms, any of those are at risk of having a thrombus, and that is an acute emergency, and you need to recognize that and open up that artery. The skin changes that occur, you'll see thickening of the nails and drying of the skin. You may see hair loss in the lower extremities, legs, feet, and toes. The color temperature is generally pallor type look. And it can have these lines of demarcation that you see where they actually have a poor perfusion versus adequate perfusion. The temperature may change as well from this demarcation period. Maybe muscle wasting, like they get smaller from the chronic ischemia. And if this progresses, they can develop ulcerations, gangrene, and all kinds of complications. This just shows you what the ankle brachial index is and how they measure it, and that gives you the formula. You won't need to know that, but it's for your FYI only. Okay, so we're gonna medical management. We want to help control some of the factors that lead, or the risk factors that led to the diagnosis. So lifestyle changes, promote rest and pain relief. Patients pharmacologically may need to be on things like anticoagulation, vasodilators, antiplatelet agents, antilipids for the athero disease. Um, the patient will need to be oftentimes on antihypertensive as well. And hopefully these can help maintain perfusion so these patients don't have complete occlusion occur that can threaten limb. These patients may be candidates for angioplasty or placing of stent into the areas where those lesions are, just like we do in the heart. So pushing up that athero plaque against the vessel wall and then putting a stent in to keep perfusion there. And then also sometimes we need to do a bypass as well if we are not able to stent and do the athero or angioplasty. So once again, they are at risk of amputation. We need to monitor these patients, assessing those pulses. Always compare both sides, document color, temperature of that extremity. Use the Doppler if you can't palpate a pulse. Look at the skin. Really try to avoid any type of pressure. They're at high risk for any type of skin breakdown due to the low perfusion state. So we want to protect them from that as well. Knowing that if there's a sudden change, this is emergent, we need to remove that thrombus is the only way that we're going to salvage that ischemic tissue. So usually it's a thrombus that causes the emergent intervention or emergent urgency of removing a clot. Education and how to help manage some of the symptoms at home will be important as well. I think I already covered this in the other lecture, but essentially, this is one of the complications that can occur with cardiovascular disease is they can actually get plaque into the carotid arteries, and treatment for these are going to be angioplasty and stent or carotid endarterectomy, or actually removal of that clot itself. Essentially, management for carotid artery disease is going to be focused on whether a patient is symptomatic or asymptomatic and the percentage of occlusion in that vessel itself. So we call that stenosis or high-grade stenosis or carotid stenosis. These patients need to be on what we call dual antiplatelet therapy. So that's what's referred to as DAPT. That is going to be like Plavix and aspirin. So two different antiplatelets will be needed. And then these patients need to be on statin. So we may need to also control their blood pressure before we actually go in and do any type of opening up that carotid artery. So this could be something that's done on an outpatient, or if it needs to be done emergently, we'll do it in the hospital. But they generally need to be on an antiplatelet for 3 days prior to a stent placement. Okay, so here we have a venous problem. So we have venous thromboembolism. Conditions that related are DVT, deep venous thrombosis, or pulmonary embolus. Essentially, it's a clot that forms into a large vessel vein. It can happen in the pelvis, arms, and legs. It's usually accompanied with inflammation, pain, tenderness, redness at the site of the thrombus. Essentially, there is a clot that migrates through the venous circulation and could end up in the pulmonary vasculature, causing pulmonary hypertension and the PE that can lead to a cardiac event and even cardiac arrest. depends on how big it is. So this can happen from procedures, immobility, can happen from infection, inflammatory response, immobility, trauma, major surgery, cancer, hereditary, all kinds of things can cause this. Women that are on contraceptive pills or estrogen is also at risk. So essentially, referred to as the Virchow's triad. You have three things that's causing this: stasis of blood, endothelial injury, and hypercoagulability, and that can promote clot. Some are asymptomatic, some are not. That throbbing type pain might bring them in. They tend to have pain more with ambulation. Positive Homan sign, which isn't super reliable, but it's pain in the calf on dorsiflexion. You will never rub that leg, but it's not a really good reliable marker. For DVT, you can draw a D-dimer. It's going to tell you there's clot, but it doesn't tell you exactly where. The patient may have mottling, cyanosis, and depending on how big that clot burden is. And so a good assessment is going to be important. For ruling out a PE, we may do a CT angio, which is the gold standard. And then we also can do a VQ scan as well. If the D-dimer comes back negative, it's pretty reliable. That's not clot related, but it doesn't mean we know where the clot is. So ultrasound will help identify a DVT. It's useful in diagnostics. Essentially for the pulmonary embolus, sometimes if the patient is so unstable, we may not have time to even get that first diagnostics. Those patients may have sudden shortness of breath, tachycardia, for some unknown reason is one of the hallmark sign. If we can, if the patient develops ARDS for some unknown reason, so lots of different things to think about, but PE is going to be one of the big differentials on a sudden change, like I just described. Okay, so medical management, we're going to put them on anticoagulation, could be low molecular weight heparin, or unfractionated heparin. We want to help prevent any further clot with early mobility using our SCD compression devices. Make sure we're monitoring the patient for bleeding and further clotting, make sure they're in a therapeutic range. If there's an acute phase of VTE, we can treat with IV heparin or sub-Q, low molecular weight heparin. Put them on some of the new anticoagulation agents like apixaban, for example, antiplatelets with aspirin or Plavix as well. We may treat them with any one of those agents to help reduce the clot, and then get definitive diagnosis as well. We already talked about what would happen in a patient with a PE, so hemodynamic deterioration, sudden tachycardia, even cardiovascular collapse can occur. Sometimes we can do a catheter-directed fibrinolytic therapy and actually lyse the clot directly with TPA, for example. And if they're prone to clot, we may place an IVC filter in to help prevent further PEs from occurring. So nursing management is going to be make sure we administer the anticoagulation, make sure they've got them mobile or have some range of motion on other extremities so they don't get additional clot burden. Avoid bending at the knees or hips because it impedes venous flow that can promote clot. Anti-embolic stockings can be used during walking. Teach them what the signs and symptoms are, elevate the extremity to decrease venous pooling, and take medication as prescribed. Okay, so we're ending with hypertensive emergencies. It's defined as acute severe increase in blood pressure higher than generally 180 over 120 that results in acute end organ damage. So hypertension crisis is elevated blood pressure, but when you become a hypertensive emergency, that you've got evidence of end organ damage. So you've got something going on with the brain, so they may have stroke or a heart attack, any type of change in their creatinine, for example, change in vision, they've got a headache, any of those evidence of end organ damage, that is your hypertensive emergency, and we need to get the blood pressure down. Someone with hypertensive urgency, or they have essentially uncontrolled hypertension, I've really walked around with blood pressures, elevated blood pressures for quite some time, and reducing that too quickly is going to result in a loss of autoregulation to the brain, and the patient can have rebound hypertension or really drop their blood pressure and have a stroke as one of the outcomes. So we only want to reduce the blood pressure over time, slowly, but with hypertension emergency, we need to drop it a little bit more quickly, and we need to get them on an agent as the organs are starting to fail. So that you can see some of the signs and symptoms that may occur and some of the causes here for hypertension emergencies. So cardiovascular wise, chest pain, they may have an acute coronary ST elevation, IMI, or NSTEMI. They could have acute dissection, may have sudden onset of acute heart failure from an MI or PE, for example. Neurologically wise, they may have a headache, they may have palpedema, agitation, delirium, seizures, or coma, and this could be from hypertensive encephalopathy from that high blood pressure. They could have ischemic or hemorrhagic stroke and increase intracranial pressure. Pregnancy, the cause could be from eclampsia, and eclampsia can occur as even several weeks after delivery. As the body starts to transition from being pregnant to non-pregnant state. Kidney failure can occur, and they may end up having to go on dialysis temporarily. Catecholamine excess from things like cytochromia, I can never say that word. So you've got a mass tumor that releases things like epinephrine and norepinephrine that causes a sudden rise in blood pressure. And then it can also be medication related. So these are some of the emergencies we see with elevated blood pressure. So essentially, how we diagnose it as an emergency is when we see end organ damage, as you see on the chart. It looks like some of it's got cut off, but we went through it already. We talked about the goals of therapy is to reduce that blood pressure without compromising organ function. It's really going to depend on the cause itself, but if they don't have end organ failure, we want to drop them more slowly. So 20-25% over periods of minutes to several hours when we have hypertension emergency. That's how quickly we want to drop the blood pressure, about 20-25%. We want to make sure that we don't use agents that are going to bottom out the blood pressure as well. So best is use agents that are IV given, such as nipride, some beta blockers we can use as well. ART lines are really important to have when you have hypertension emergency to keep that blood pressure range really close in the target goals. If patients have systolic blood pressure greater than 220 over 120, we're going to lower those a little bit more slowly at 10-15%, and monitor for any signs of end organ damage. So if they start to get altered, we worry about them having a stroke. If they start to show signs of AKI, we're worried about the kidneys are shutting down. So we want to be really careful about that. We want to do careful monitoring of all the symptoms, and like I said, give the blood pressures usually intravenously. We don't like the peaks and valleys with oral agents. It's always best when you've got a critical patient to use intravenous, short-acting antihypertensives so that you don't have sudden surges of elevation and drop, because elevation, you can understand the risks of that. You can have a bleed under, drop the blood pressure too low, you lose perfusion and can have a ischemic event. So it's really going to depend on whether the patient's in a hypertension emergency versus urgency, and then how we're going to manage that. So all different types of agents can be used. It's individualized to the patient, and hopefully we can reverse the end organ damage. So that is all for cardiovascular, and we will do a review before the exam, but essentially that's in a nutshell. Thank you.